So I have the pleasure now of introducing Dr. Russell Sawyer, who has a special place in my heart. He trained here at UC in the residency program, and then went on to do a fellowship in cognitive neurology. And he's going to talk to us today about thinking and memory in Parkinson's disease, practical knowledge. What can you do? So Russell, please.
I'm going to say we're going to stand over here. I have the unfortunate position of following Cheryl, who was amazing, and Maureen, so this will be a little bit of a letdown after them, who were both fantastic. This is going to be putting into perspective some of the principles. We'll talk a little bit about the science, but really I'm here to give you a little bit of my perspective, a little bit of my knowledge, and really to empower you, not only in recognizing the thinking and memory problems, which I'm a thinking and memory doctor, so my opinion's a little skewed that I think we talk about too little, and giving you ideas about, okay, what should I be doing about this? What should I be talking to my doctor about? So I apologize to all of my fellow physicians, but hopefully now patients are going to be asking a lot more pertinent questions. So we're going to dive right into this. So I like to lay the groundwork, and I like us all to be using the same words because I am a simple person. A lot of times you'll hear in media, you'll hear even other doctors using these terms interchangeably, and I want us all to be using the same sort of vocabulary. Since I'm up here, I get to bias you with my vocabulary. So when I talk about thinking and memory problems, I talk about them in two ways. The first way is how severe it is, and that's what we're going to talk about here. The second way is what causes it. Those are two very different columns, and we'll get to the underlying causes of it in this talk, and we'll get to the terminology for it now. When I'm talking to somebody, and when I'm talking to my patients, I say, this is how severe your thinking and memory problem is. What we describe as normal is you and your family say, I don't have any thinking and memory problems. I'm doing great. I'm doing everything that I was doing 25, 30 years ago. Not a problem. I do my objective testing, which is paper and pencil testing to test how fast your thinking is and doing all of the multitasking. And I agree. I say, yep, I agree. Your thinking and memory looks completely normal. That's fantastic. Then there's this concept called subjective cognitive impairment. This is one where you may say, you know, it takes me a little bit longer to do the things that I used to do. And not because I'm having slowness of movement, but I'm having more difficulties with my thinking, with my processing speed. These are people that can typically are still working and say, you know, it's just I'm having a little bit more trouble at work. But their families, their friends, their coworkers may say, you know, I don't notice that. I think they're doing fine. Unfortunately, this was a group of people, and they come into me, I do my paper and pencil testing, it's completely normal. Unfortunately, this was a group of people who maybe 10, 15 years ago was dismissed as, oh, this is normal aging. Let me just dispel that right now. There is no concept of your thinking and memory declines normally as you age. If your brain is working perfectly and you are doing everything that you should think as well when you're 95 as when you're 25. So I tell people, anytime you tell me, I've got some changes in my thinking and memory, I need to take that seriously as a physician. So these people early on were dismissed and said, oh, that's normal aging. Oh, you're anxious. Oh, you're neurotic. I think there's a good chunk of people in the room that are in a position now where they said, yes, I saw, and I was bringing people complaints, what I thought very, very early on, and one physician or another said, no, that's just normal. I want to kind of dispel that idea. So that's what we call subjective cognitive impairment. Mild cognitive impairment is you and your family may say, thinking and memory is a little bit off. It's not as good as it used to be 5 years ago, 10 years ago. I do my paper and pencil testing, and yeah, there's some abnormalities, but you can still do a lot, maybe not all, but a lot of the things that you used to be able to do at home. This is what we call mild cognitive impairment. And mild cognitive impairment is probably the longest phase, and it's certainly the most common thing that I see. But it's not something that we hear a lot and talk about. Now, my audience right now is very informed, where you're getting taken care of by some of the best physicians that I've ever had the opportunity to work with, and you guys are reading, and you're interested, and you're involved, and you're here. So this audience may say, oh yeah, I've heard of that. That's something that I know about. But the general population has no idea. What the general population does hear about are words like dementia. When I hear people, they come in and say, what's dementia? Dementia is Alzheimer's disease. Dementia is Parkinson's disease. Our next phase is the one that we're going to talk about. Let's bring that slide up. Ooh. Mild, moderate, and severe. So we're talking about severities. Normal is no problem. Subjective cognitive impairment is, yeah, I think something's off, but I have no testing that shows there's an abnormality. Mild cognitive impairment is, yeah, something's off. You're experiencing it at home, and my testing is not normal. And then we get dementia, mild, moderate, and severe. And mild, moderate, and severe dementia mean you're having impairments in activities outside the home. So because of thinking and memory problems, not because of motor problems, you aren't able to do things like drive, carry out activities like going to the grocery store because you're having those thinking and memory problems. That's sort of the mild dementia component. When you get to moderate and severe, you stop being able to do things within the home, and then eventually stop being able to do self-care. Again, this isn't because of a motor problem. If I had broken my arm and I need help washing, that doesn't mean that I have dementia. That's because I have a broken arm. If I have stiffness that prevents me from doing it, but I can guide somebody how to do my day-to-day tasks and my day-to-day care, that's not dementia. When we're talking about thinking and memory problems and you start having difficulties going to the grocery store, when you start having difficulties cleaning the house, unpacking the groceries, and when you start having difficulties of self-care because of thinking and memory problems, that's when we start talking about mild, moderate, and severe. And those have testings that go along with it that I won't go into. But this is sort of the language of how severe it is. Now, I haven't talked about the underlying cause for that at all. I haven't said, okay, Alzheimer's disease always results in dementia. Parkinson's disease always results in dementia. Because there are those things that can cause it. But I have people with Alzheimer's disease that are normal. They're very high functioning. They run companies, they're lawyers, they're doctors, and they have Alzheimer's disease changes in their brain that I've confirmed. I have people with Parkinson's disease that are the same way. They are cognitively normal. And then I have people with very, very uncontrolled diabetes, and we'll talk about that a little later. When your blood sugars are constantly 600 and 700, you'll test in that dementia range. So how severe it is does not tell me what that underlying condition is. We'll talk about the underlying conditions that can lead to thinking and memory problems, and these are some of the things that we should be asking our physicians. You know, what about this? Let's check this. I'm noticing that I'm having thinking and memory problems. I'm going to give you the tools to investigate all of these things and ask these questions about them. Let's just talk about how common this is. This was at the time that people were diagnosed. And let's see if they'll let me. So there we go. If you can see this. In the top right, this is the 28% or the percentage of people that had no evidence, either subjective, meaning the patient saying, you know, I've got some thinking and memory problems, or objective, meaning I did paper and pencil testing and there are abnormalities. So only 28% of people in this study had no signs of cognitive impairment at the time of diagnosis. So that means roughly 3/4 of people were either saying, yeah, I've got a thinking and memory problem, or when I do testing, it was impaired. So if this is at the beginning, what's it going to be like 10, 20, 30 years into the illness? So cognitive impairment is sort of an under-recognized, underappreciated component of Parkinson's disease. And hopefully today I'm going to give you some tools to go and bother your doctors and say, hey, let's talk about this. Let's talk about this. What are you doing to address this? So it makes it easy if we talk about the types of complaints. We've learned a lot about dual tasking and multitasking, and we'll touch on those. That's going to be in sort of our working memory. But these are some of the complaints that you would hear. Attention, processing speed, working memory, visual, spatial, and word finding. And I'm going to just give you, taken from my clinic notes, what people have said to me with this. Attention. So attention is, if I told you, remember this phone number, and I just want you to repeat it back to me, that's simple attention. So complaints that happen when you have impaired simple attention, and you can look around, are he repeats the same questions all day. We're going to dinner at 5 o'clock with Jerry and Susan, and then 7 or 8 times that day he says, what time are we going to dinner today? Who are we going to dinner with today? What time are we going to dinner today? That's impairment in simple attention. She has difficulty finishing a task once we get started. Attention means our ability to focus and complete tasks to the end. So if you find yourself starting projects, starting repair projects, and you're uninterrupted and you just say, you know, I just can't get to the end of this, that's impairments in simple attention. And that's A lot of things, both Parkinson's related and unrelated to that can cause difficulties in simple attention. Processing speed complaints, and this is particularly relevant to Parkinson's disease, but even outside of that. And we'll talk about tons of things that can cause processing speed complaints. In a conversation, her responses tend to lag behind, and not just because of that sort of motor slowness, but in slowness in thought. I had one person, it was a great description. He says, it takes me longer to think of something than it used to. So that's processing speed. Working memory complaints, we've kind of learned about the tasks to do them. We were just doing them. The Stroop color test is actually a test of working memory. Your dual task, your multitasking. This is you're doing something, you're interrupted, and suddenly you have so much difficulty going back to it. You can't multitask anymore. Any interruption, the smallest one is going to throw you off and derail you. That's difficulties in multitasking. So hopefully these are giving you ideas about, oh, okay, yeah, this is a problem. This is what I'm hearing at home. This is what I'm seeing from my spouse at home, or this is what I'm seeing in myself. These are the kinds of cognitive complaints that arise in Parkinson's disease for a variety of reasons, and we'll go over those. Visual spatial complaints, and this one is one that happens quite a bit to me. Yeah, we always scrape the same side of the car. I always scrape that left side of the car. In fact, the last time, we knocked the side mirror off the left of the car. Another one is, the remote control's right there, and they're reaching for it, and they're reaching in all these different places. These are actual complaints that I hear with people in clinic. It's right in front of them, but they have no idea where it is. So those are visual spatial complaints, and all of these are sort of the cognitive complaints that we see related to Parkinson's. And probably the most underappreciated for me is word finding difficulties. I have patients that say more and more it's difficult for them to come up with the name for something, or they can think of the name, but it's 10 minutes later or an hour later. The telephone is that thing that rings, you talk to people on it, you slam it down at the end of the conversation, and then later on, they can come up with that. So word-finding complaints. So all of these are the sort of things that you'll hear in somebody that's having cognitive complaints. So we need to touch on what are those causes, because I think everybody here has, we have Parkinson's. It's affecting our lives, where it's affected ones that we know. But a lot of times, Parkinson's gets a lot of things ascribed to it. I think one of my favorites was I had a patient with some hip pain, and they'd gone to their primary care doctor, and they said, hip pain, very, very common in Parkinson's. I'm not saying that they're wrong. Then when we got an x-ray and we saw that their hip was dislocated, it was probably not the Parkinson's that was causing it. The same way, there's a knee-jerk reaction to ascribe these symptoms only to Parkinson's. And that's really, we're missing out on a huge opportunity to affect change and improve quality of lives if we just say, that's Parkinson's, you're taking your Parkinson's medicines, I'm gonna give you another pill to help with thinking and memory in Parkinson's, when really we could be missing the boat. So these are things that I want you to advocate for, and your physician should be thinking about and looking at, because these are huge things that can change quality of life in thinking and memory. I think the biggest one, and this is me as a physician as well, you see a doctor and the doctor's knee-jerk reaction is you're having a symptom, you're having a complaint, let me give you a medicine for it. And we live in an age where it's not just you see one doctor, you probably have a primary care doctor, you may have a Parkinson's doctor, you may have a cardiologist that sees you, you may have bladder problems, so you see a urologist or a bladder doctor, you may have breathing problems, so you see a lung doctor, you may have kidney problems, so you see a kidney problems. All those doctors, I would love to say we talk as much as we do, but a lot of them will say, oh, I'm going to just prescribe this. I'm going to prescribe this. And you've seen in a month 4 doctors, and 4 doctors have put you on 4 different medicines, and this is what gets you into difficulties. Medications are probably the biggest thing that can contribute to the thinking and memory problems in Parkinson's and the things that we were just talking about. And some common things are antihistamines, anticholinergics, cold medicine, and these are available over the counter. We live in Cincinnati. It's a city of 4 seasons. If you get a runny nose, it's either, oh, I have a cold, or I have seasonal allergies, and you take those medicines. I have people that say, oh, I've been taking seasonal allergy medicine every day for 5-10 years because it helps with my allergies. Long-term use of medicines like antihistamines, cold medicines, allergy medicines, they have this what's called anticholinergic component, and that can lead to long-term changes in the brain and can long-term thinking and memory problems. The brain actually functions differently when you're on those medicines compared to when you're off of them. Another common effect is another common drug that can cause that are medicines for bladder and GI. So a lot of people, especially men, come to me and they're like, oh, I'm having some urinary leakage, I'm having some bladder problems. I saw a urologist, they put me on that medicine. Those medicines can cause thinking and memory problems, not just from the day that you take them, but as you use them long term, they create long-term changes in your brain. Now, it's always a balancing act. Every condition, we have to weigh the risks and benefits. I'm biased, I'm a thinking and memory doctor. I have people coming to me saying, my thinking and memory is off, I'm having difficulty. And the easiest thing to do is look at that list of medicines and say, these need to come off. I'm gonna highlight one thing on there. There's anti-Parkinson's medicines. These were old medicines that had anticholinergic properties. These aren't the medicines that we're using today. So things like carbidopa, levodopa, those are not the ones that we're talking about. These were ones that were much, much older in use. So, medications, sleep. Sleep is a huge, huge problem. Disclosure, I have a 15-month-old, so I had a year of not sleeping through the night because he was up, that meant my wife or I was up. When you're not sleeping, your thinking and memory is terrible. I told people that once my kids start sleeping through the night, I'm gonna be 30% smarter because I'm just exhausted all the time. I can't think. The problem is after you've had 5, 10 years, even just 1 year of being chronically sleep deprived, getting chronically low quality sleep, you dumb things down. Your brain is not functioning as well. Sleep is so important, we devote a third of our life to sleeping. 8 hours overnight. Why do we do that? There's lots of research that in the deep stages of sleep, that's when our brain is clearing all of the toxins that accumulate during the day. These special, and sorry, fancy doctor medical term, glial lymphatic channels open up and all of these toxins that accumulate through the day through our normal brain activity get washed out into the lymphatic system and that clears. When we're having sleep problems, when we're not getting into deep stages of sleep, when we're not getting enough high quality sleep, those toxins stick around. The example that I use is sleep apnea. Now, sleep apnea is when we're talking about obstructive sleep apnea, it means you stop breathing at night when you sleep. And I have people that say, no, that would definitely never happen. People usually, we think of people snore, heavyset people, big necks, they snore, their soft tissues collapse in their airway and they can't breathe. When your brain can't breathe, it wakes you up from sleep, you take a deep gasp, and then you go back to sleep. The patient is never aware that they've woken up and taken a deep gasp. When you're doing that, and there are people that have sleep apnea and stop breathing hundreds of times in an hour. I think the highest I've seen is 156 times somebody stopped breathing in an hour. You're not getting deep sleep. You're not getting into those deep stages of sleep. You're not being restorative. You're not taking away those toxins. So untreated sleep apnea leads to accumulation of those toxins. Untreated sleep apnea is actually one of the strongest risk factors for developing Alzheimer's disease. Because you're not clearing those toxins, they stay around in your brain, they start to form all the changes that happen in Alzheimer's disease. So what I always do is I'm screening for sleep problems, even in people that say, oh, I'm not sleepy. I sleep great. As soon as my head hits the pillow, I fall asleep. They're like, yeah, he sleeps all the time. He could be sitting in a chair and just falls right asleep. That means that your quality of sleep at night isn't good. None of us should be, I'm not that excited of a talker, but none of us should be sitting here and then falling asleep immediately during this conversation. That's signs to me that sleep isn't the quality that it should be. Or, oh, he sleeps great, he's in bed for 15 hours. We shouldn't be in bed for 15 hours. After the age of about 55, we should only be in bed for 7 or 8 hours. So if you're getting to be in bed for longer periods of time and you're sleeping for that, the question needs to be asked, is my sleep as it should be? So, medical problems, and this were things that we talked about. The heart problems, lung problems, kidney problems, digestive problems, all affect our brain. Our brain gets our nutrients from the blood, and it needs to draw those out. So when we have things like heart issues, our heart failure, our heart's not pumping as well as it should be, that affects our thinking and memory. When we have breathing issues, we're not getting enough oxygen at times, we're starved for it, that affects our thinking and memory. When we have kidney issues and kidney damage, and we have liver issues, liver damage, that affects our thinking and memory. So these are things, general things that can be checked for. And I tell you, treating Parkinson's isn't necessarily gonna make your heart better. It's not going to make your heart pump better. That's why you need to get the appropriate medical examinations for these things. Probably the lowest hanging fruit are, as we age, we have more difficulties with hearing and vision. I've actually had several people that were referred for dementia, so severe cognitive impairment, and I'm asking them to do tasks, and they're having a really difficult time with my paper and pencil testing. And I ask, like, oh, do you wear glasses? Because there was a lot of squinting. And they're like, oh, I've never worn glasses. We sent them to an eye doctor. They needed such a big prescription. They got that prescription, they come back, they redid their testing, and it was essentially normal. Why? Because they weren't able to see and interact with their environment. Same with if you're hearing. If you're having difficulties following a conversation because you can't hear somebody, that's a big issue. And that is, again, totally different from treating underlying Parkinson's disease. This is just to emphasize that vitamin deficiencies, things like B12, folate, can cause long-term thinking and memory problems. So those should be checked routinely. I tell people you don't necessarily need to be taking an over-the-counter multivitamin. If you're taking one, usually anything that you don't need is being urinated out. But if you're coming to the conclusion that you have some thinking and memory problems, this is a low-hanging fruit, something that's easy to take care of. It's easy to be checked for. These are routine blood tests that can check for vitamin deficiencies. So, sorry, this is a CAT scan. The big emphasis is on the right side of the picture. There's this long, dark crescent. That's actually blood that's accumulated over time. As we, especially people with Parkinson's, fall, we can hit our head and have collection of fluid or blood or things that can push on our brain. This is just to emphasize that we need to be assessing what does the brain look like at times. Now, this is a conversation with your doctor. It's usually not things that happen spontaneously, but these are things that need to be addressed, maybe be asked about. I've had patients where I've seen them for 5-10 years and they haven't had brain imaging. We get brain imaging and it's something completely different. It's not Alzheimer's, it's not Parkinson's, it's something we see on the brain imaging. So this is just a question that you need to be asking. Say, hey, I haven't had brain imaging ever. I've kind of got these new thinking and memory changes. What do you guys think about taking a picture of that? It's a conversation to have. We have an MRI scan on the left and we have a chest x-ray on the right. I see a large population of people that have either had cancer, are currently having cancer, or have been treated with chemotherapy, radiation, and those issues. All of those, having cancer, puts you at higher risk for thinking and memory problems. Cancer can metastasize, unfortunately, to the brain sometimes, and those are issues that need to be addressed separately. And then the medications that we use to treat cancer that have been effective tend to cause thinking and memory problems as well. So it's always a balancing act, especially if you have a long-standing cancer history or even a family history of cancer, to ask that question of how does my cancer risk affect my thinking and memory? Again, this is a conversation that you have with your doctor. If you're somebody who has never had cancer, nobody in your family has cancer, and you have no risk factors for it, it's probably not the underlying cause. But I've had plenty of people that came in and I've had 3 or 4 different types of cancer, I've been on chemotherapy, on and off for the last 25 years. And I say, yeah, those are things that'll affect your thinking and memory, not just in the short term, but in the long term. So these are questions for you to be asking your physicians, your providers, saying, what do we do? Because again, if there's cancer, that's a completely different treatment than if we were saying this is all due to Parkinson's disease. Now we kind of transition to, okay, we've done the evaluation. We've done, I've asked, I have thinking and memory problems. I've asked and we've evaluated for all of these things. What do we do about it? The biggest thing, I think, is the medical optimization, which means finding and treating anything that's reversible. The things that we talked about. And then we're going to emphasize a little bit of diet. We've had lots of people talk about exercise, and I know Dr. Vaughn's going to touch on it a little bit later. I hope I've drilled into you that sleep is particularly important. We'll talk about new learning and how that helps us, and then we'll talk about the value of socialization. I'm counting on Maureen to give me the quick pull if I start running over. So diet, I tend to advocate for the MIND diet, and there are lots of different diets. One's geared towards Parkinson's disease, one geared toward the motor symptoms. I advocate for the MIND diet, which is sort of a mix of the DASH diet and the Mediterranean diet. I have to be honest, I was very skeptical, and this was me being very young and naive. I was very skeptical about a diet making a huge difference in people's thinking and memory. And they followed people over time that were on this MIND diet or a mix of a Mediterranean and a DASH diet. And there were dramatic differences at 1 year, 2 years, and 5 years in people's thinking and memory. And I said, you know, I think that we may be missing something, at least I was in my practice, that I wasn't talking about this enough. The emphasis of most of these diets are, let's reduce some of the things that are bad, and let's emphasize some of the things that are good. The concept is, let's get more antioxidants, let's get more things that reduce inflammation. So having whole grains. What I tell people is the foundation for this is dark leafy greens. So I have lots of people where I say that and they say, oh, I have iceberg lettuce every day. That's great. That doesn't have a lot of the antioxidant things that you want. So these are the dark, bitter greens, the spinach, the kale. Those things need to be the green leafy vegetables that you're getting. So I'm getting you have 3 minutes. So diet is super important and can make a huge difference. The next one, this is the data showing that. This one's exercise, and I think we all, as people that are affected by Parkinson's, know how important exercise is. Exercise helps us stimulate. We talked about some stem cells earlier. There are stem cells that are sitting in your brain and can be stimulated to become brain cells. Cardiovascular exercise that gets your heart beating, like what we were doing earlier. I was really short of breath from that. That stimulates these stem cells to become mature, what we call neurons. Those are the brain cells that function. But it's the cardiovascular exercise that does it. This table here just shows that people that exercise, which is the dark band, their tests tend to improve. The one on the bottom left, that's a time test, so it's actually less is better. That means you're doing it faster. People that do regular cardiovascular or regular exercise perform better in the short term, meaning weeks to months, and then if they can sustain their exercise, sustain those benefits in the long term. We've talked a lot about the brain games and those activities. What I like to emphasize is what helps stimulate these stem cells to become new neurons, new brain cells that can help us with thinking and cognition. The cardiovascular exercise is huge. Learning and new learning. Now, I apologize to all of the people that are teachers and were teachers. There were plenty of times when I was in school and I learned facts and they were boring and I never remembered them. But I can tell you absolutely about the planets because I was interested in being an astronaut. I was excited about that. When you're excited and engaged and want to learn about something, that stimulates brain cells to grow. Not when you're doing an activity where you're like, okay, I have to sit down and do an hour of Sudoku. If you don't like doing it, it's not going to help stimulate new brain cell growth. So I tell people, do activities where you're engaged. Do it with people. Go to activities that really get you excited and learning. If you like art, go to art museums. If you like mechanics, go to all of the great airplane museums that we have around. And all of these pictures emphasize, do it with a group of people. When we socialize, when we interact, we learn more and we help those brain cells to grow. This is my last slide. Thank you for your attention.